right, good afternoon. I'm Jessica Berg, one of the co-deans here at the School of Law, and it is my privilege to welcome you to the 2023 Melman Lecture in Health Law. The lecture was named in honor of Max Melman, the Arthur E. Peter Silge Professor of Law. Max joined the university in 1984 and in 1987 became the director of the Law Medicine Center, following Ali Schroeder, who founded the center. He received his JD from Yale Law School and holds 2 bachelor's degrees, one from Reed College and one from Oxford University, which he attended as a Rhodes Scholar. Prior to joining the faculty, he practiced law with Arnold and Porter in Washington, D.C., where he specialized in federal regulation of healthcare and medical technology. Professor Melman is the author of 18 books and over 90 articles and chapters. And in 2013, he was named a Distinguished University Professor, which is the university's highest honor. Max's extraordinary work here at Case Western Reserve University prompted the generous donation establishing this named lecture. The series allows us to bring in high-profile speakers in health law, all of whom are graduates of our law school. Up until now, the benefactor of this lecture, Dr. Eugene Pergament, had remained anonymous. I had the privilege and honor of meeting Dr. Pergament a number of times. With his passing earlier this year, his daughters, Deborah and Rachel, both of whom are here today, gave me permission to identify their father by name. Dr. Pergament was an extraordinary man. He believed strongly in the adage, you can do well by doing good. A pioneer and international leader in the field of reproductive genetics and an advocate for reproductive justice and the rights of children with disabilities, Dr. Pergament was also a philanthropist supporting many causes. That support included not only generous donations, most of them were done anonymously, but also his time and attention. While we mourn his passing, we're so pleased to be able to acknowledge that support today. Please join me in recognizing him and thanking his family for this named lecture. It's now my honor to turn the podium over to Professor Max Melman, who will introduce the speaker for his lecture.
Thank you, Dean Berg. Welcome to the 2023 Melman Lecture. Our Melman lecturer for this year is Sheldon Green. Sheldon has had a remarkable career. At our law school, he was an editor of the Law Review, winner of the Dunmore Moot Court Competition and the Contracts Prize, and he graduated Order of the Coif in 1958. He was appointed Warden of Insurance of the state of Ohio at the age of 23. He was House Counsel to the Pennsylvania Life Insurance Company. He served as General Counsel of California Rural Legal Assistance. He was a member of the founding board of the New Israel Fund and lived in Israel for 2 years, where he worked on the National Archaeological Survey. He was a partner in the law firm of Green and Allison in San Francisco. He's the CEO of Oak Creek Energy, a wind energy development company. He's a member of the board of the Great Lakes Energy Institute at Case Western Reserve University School of Engineering. He's published 5 novels with excellent critical reviews, as well as numerous articles. He was a member of President Obama's national policy teams on energy and immigration. And he's been a member of the Nancy Pelosi-initiated San Francisco-based Red to Blue group. The title of Sheldon's talk today is Healthcare Delivery in America, Its Weaknesses, and How to Make It Better. Please join me in welcoming Sheldon Green.
Well, thanks for the honor and the opportunity to share my thoughts with you on this subject. Having listened to your resume, I think you should be the speaker and I should introduce you. But given that we've gone as far as we're going to go, I'm going to have to go with it. So everybody fasten your seatbelts because we'll try to run through this subject for over about 45 minutes and reserve your questions or comments or criticisms until the end, and so that we can have continuity. Okay, American healthcare is an unmortared mosaic of providers and bureaucracies, absorbing 18% of our GDP and wasting $600 billion in unnecessary administrative costs. Now, that's the punchline. You can quit now if you want to, and don't want to know who done it. But here are the details. The discussion will explore our healthcare payment and delivery system, and the role played by the government and private insurance in administration and payment. Other systems, particularly Canada, the UK, will be discussed and compared to ours. We'll also weigh what, if anything, can be done to improve the system as to cost and effectiveness in delivering needed services. We'll speculate on whether the government really has a primary obligation to provide such services, a jurisprudential issue. And finally, we'll list 8 incremental changes to mitigate the current weaknesses. So we can divide this initial review of the system into 2 components. One, the people who provide the service, and the other is who pays for it. So the American healthcare delivery system absorbs $4.3 billion, or $12,914 for every person. It's delivered at 135,000 medical offices by 230,000 medical practices, over 6,000 nonprofit and for-profit hospitals, 2,000 mental facilities, 15,900 nursing homes, and 11,000 home health agencies. The healthcare industry has a big economic footprint. According to a 2020 study, it absorbs 24% of government spending, 8.1% of private spending. It employs 1 in 10 of all workers in the United States. And 2 notable red flags are the fact that the expenditure on health is 2 times that of other developed countries. The cost for a hip replacement, for example, is 5 times the cost as it is in Netherlands. And the cost for the same blood test in the United States has varied from $22 to $952. Now, the backbone of the healthcare delivery system is the hospital, over 6,000 of them nationwide. And they're as varied as the states. They're nonprofit, for-profit, independent. 68% of them are tied to healthcare systems. And they range from rural facilities with 25 beds to research and treatment campuses like the Cleveland Clinic, not to mention the one that's here on this campus as well. They absorb $1.2 trillion of our healthcare expenditures. And in 2022, half of them were losing money. So where there's a problem, Washington has always supplied a Band-Aid. And when they come up, for example, a good example is rural hospitals. They lose money because so many of their people are dependent and have low insurance and have economic disadvantages. So the government has provided a subsidy to them to keep them going. And you will see as this discussion progresses, each one of the legislative initiatives is sequentially intended to fill a gap and make them more efficient. So while some hospitals are standalone, two-thirds of them are participants in healthcare systems. These systems vary in scope and scale. 7 of them combine each 100 hospitals. Kaiser Permanente is a good one to examine. It was started in 1942 in Oakland, California, and it now serves 12.6 million members in 8 states and the District of Columbia. It operates 39 hospitals and 737 related facilities on a $90 billion budget. Now, it is significant in a couple of respects. First of all, everybody at Kaiser is working for Kaiser, and they're not on a fee-for-service basis. And one of the most significant initiatives is that they pioneered integrated electronic records for all your health systems, as well as telephone and video doctor visits. I have to say, I'll disclaim something because I happen to be Judy and I, are long-term members of Kaiser. So we have a lot of positive things to say about it, but we'll save that for later. Another format is the community health center. Conceived during the war against poverty, they are organized to provide quality outpatient health care to the rural poor and to the underserved. There are 23 million people who are served by this system in 1,400 neighborhood clinics and in 9,200 communities. An aggregate of 270,000 healthcare workers are engaged in what is the largest nonprofit a primary care initiative in the United States. The Veterans Administration is freestanding, as I think everybody knows about that. They operate 171 centers and 1,100 outpatient clinics, and 9 million veterans are covered, as well as their families. There is also an independent Native American care system, which is free, and it's placed in places so that people get the assistance. Now, the current drift, and this I think would interest all of you, of healthcare delivery is the acquisition and consolidation of primary care physician practices by for-profit business entities. Now, CVS Healthcare is a chain of pharmacies. It actually also owns Aetna, a large for-profit health insurance company, as well as its chain. And recently, that conglomerate paid $11 billion to acquire Oak Street Health, which owns primary care centers in 21 states. Amazon has a similar horizontal configuration, delivered every day to your door, with the acquisition of One Medical. And these centers all serve older participants in the Medicare Advantage program that I'll mention later, through insurance policies that they buy. Rather than have a fee-for-service compensation, these primary care centers get a capitation from the insurance carrier, meaning a price for each member or participant. And that approach is intended to avoid unnecessary or excessive treatments. Physicians who are paid per treatment sometimes pad the bill with extra services, I'll get into that a bit later, or magnify the return by misstating the level of treatment. Doctors who are salaried under a capitation compensation plan complain of burnout from administrators' efforts to reduce costs and maximize profit. The tension between reasonable and necessary care and cost reduction and profit expansion is an endemic flaw in the healthcare delivery system. While nonprofit entities have similar needs for efficiency and are vulnerable to income that does not meet overhead, the need to provide shareholders with a reasonable return is a burden that's not shared by the nonprofit segment. The Petrus Center at UC Berkeley has done significant research on private equity acquisition of private medical practices and for-profit hospitals, as well as vertical integration of healthcare delivery and its impact on the high healthcare costs and the quality of service. At issue is the interface for for-profit health insurance companies, physician practices, and hospitals. And the consolidation has been dramatic, as has been the impact on costs, raising issues of antitrust violations. During one study, hospital and health system ownership of physician practices increased by 89.2%. The share of community hospitals in the United States that are part of hospital systems has increased to 67%. So while the acquisition of practices can generate overhead economies, this is obvious, the goal of profit-making entities with their hand on the scale, focused on the bottom line, leads to inflated costs for the care provided. And a recent study by the Department of Health and Human Services exposed the flaw in a system which gives for-profit insurance companies the right to deny compensation for needed medical services under Medicaid. Prior authorization, which is I'm talking about, was intended to prevent expenditure for unnecessary services. It also enables insurers to maximize their profits by shrinking their disbursements. The study showed that poor and minority participants have a significantly higher percentage of denials of requests by physicians and hospitals for the costs of otherwise medically necessary service. The denial rate was 25% higher with minorities. The nonprofits also are not free from blame. Here's an example. Alina Health is a nonprofit that owns and operates 13 hospitals and 90 primary care clinics in Minnesota and Wisconsin. Patients whose debt for medical care exceeded $4,500 were denied health care other than emergency services. The denial included treatment even for their chronic conditions. This approach abdicates their mission of getting a tax exemption in return for doing decent things. And an inquiry was initiated in the state, and that led them to curtail and actually terminate that program. But half of all the consumer debt is for health care in the United States. Now, payment, that's the other side of the delivery system. All the mechanisms for paying are insurance. Now, for those of you who are not familiar with this, what is insurance? It's a means to collect funds from a universe, meaning a group of people sufficient to pay for the costs incurred in providing the medical services. Fees are based upon statistical models produced by actuaries, otherwise statisticians, who collect data, model it to project future cost. And the participants pay a basic fee, a premium, and also pay part of the covered expenses through deductibles and copay. Now, a second element of the system is that historically healthcare insurance has been tied to employment. President Truman's attempt to shift the coverage from employers to a federal exchange failed. Post-war, unions expanded, and they sought health care as a fringe benefit, which increasingly deepened the tie between employment and employers. Blue Cross is an initiative sponsored by the actual hospital and medical industry, and it is 34 autonomous national programs which collectively bring in employer-based premiums and pay for the services based upon an open panel, meaning whoever shows up and says they've done the work. And that, of course, is one of the ways in which, once again, the institutions moderated the gap by providing what they regarded as a reasonable vehicle to marshal premiums and disperse them to hospitals. And I won't get into my ancient connection to that issue, but it was one of the first times that I had the opportunity to crack open and kick people profoundly when they were doing things that we didn't think was right. It actually was the first time, I think, in the United States, under the aegis of the Department of Insurance in the state of Ohio, that we engaged the fact that hospitals were not functioning sufficiently efficiently in Cincinnati and were responsible for fees that were not otherwise justified. That went to the state Supreme Court, and actually we won. So the largest of the federal government sources are Medicare, provided to the elderly, and Medicaid, available to low-income and disabled persons. Military and veterans have their own system, including hospitals, as I said before, and emergency room intervention picks up a lot of the residue. There's a loose safety net that provides services to the poor in the United States, such as migratory workers. And there is a fragmentary and partial compensation structure that still leaves many people with debts that they have incurred that cannot be met. Medicare, one of the first and most important band-aids, is the federally sponsored and partially funded program available to citizens and long-term residents 65 years of old, and also younger people who have gotten disability benefits from Social Security for 24 months. Enrollment is about 61 million people. Think of it as a long corridor with A, B, C, D doorways. A offers inpatient hospital care, B, outpatient physician's care, and not all the needs are covered, which is characteristic of our system, such as eyeglasses, hearing aids are not covered. D provides some prescription services and drug costs, and then Part C is called Medicare Advantage, and it's a package of additional services to fill in the coverage gap, which is available exclusively from private insurance carriers. The next one is Medicaid, which is coverage for the working poor, a joint federal and state program. And in 2022, 91 million people were enrolled. And the federal share of the cost is 90%, allocated by the Federal Medical Assistance Program. And to get these funds, the states have to agree to two things: to pony up the difference and to have a menu of services which are consistent with the statutory commitment in that system. The scope of services varies from state to state, and it's estimated that 84 million people are participating in one way or in the other in that system. So to reflect the diversity between the states, let's compare California's program, Medi-Cal, with Mississippi's program. I'm talking like a California chauvinist, you'll excuse me, but I'm going to talk about the flaws as well. In addition to the essential services, Medi-Cal provides extensive dental care and mental health substance abuse in counties that, if they have initiated and set up the program. So the California program expends $124 billion to serve 14 million people in California. And it has a bunch of sub-agencies, although there's one central agency, like the rest of them. The system is fragmented, given that administration is delegated to county and sub-agencies, each of which has their own minor eligibility criterion differential. And so changing from one county to the other could end up not having any service, because it is kind of a labyrinth that has to be negotiated. Here's an example of the extreme bureaucratic criterion for a single sub-program in California: managed care for eligible children. Quote, MCPs must provide for the completion of covered services from a non-contracted treating provider for up to 12 months if the member has an existing relationship with the provider and has seen the out-of-network primary care provider or specialist at least once during the 12 months prior to the transition, ... This goes on and on. And the delegation and primary responsibility is a series of overlapping bureaucracies. So if you consider this a labyrinth that has to be negotiated, you're right. Mississippi lists all of the covered obligations so that on paper it looks okay. But the devil is in the details. The glaring statistic which condemns their implementations is that life expectancy in Mississippi is under 72 years. That's less than Bangladesh. And it contrasts with Japan, which has a life expectancy of 84 years. There are a lot of factors that add to this, besides the failure of the national of their healthcare delivery system. It's a high incidence of obesity, of attendant diabetes and hypertension. The consumption of junk food and sugary soft drinks are also cultural accessories. But the failure of the healthcare institutions and the state to aggressively intervene is further evidence of a deeply flawed system. Mississippi is an example of the negative impact on health that results in the initial refusal to accept the federal 90% Medicaid subsidy. They passed on $1.35 billion. And the burden of serving the uninsured falls on 100 hospitals who expend $600 million, 8 to 10% of their overhead, in order to treat 100,000 adults whose income is under $20,000 a year. That impacts not just fiscal. They have a high death rate for heart disease, stroke, diabetes, cancer, and hospitals are shutting down or restricting their services, and the burden obviously falls heaviest on the minorities, and particularly the African American community. Now, there are other flaws that are inherent in the national program, the pre-approval obligations, the fact that changes or charges for services may exceed scheduled compensation, leaving participants who lack financial resources with exposure to the gap, and the fact that services may vary from state to state. One measure of that factor is the variance in per capita annual expenditure between the states. Ohio's is $8,534. Florida's is $5,387. Initially, 40 states refused to take up the 90%, and Texas was one of the largest of those. And over 18% of the population in Texas are uninsured, 2 times the national average. And the per capita spending on health care is $109, the lowest in the country. So the next enhancement is the Children's Health Insurance Program, or CHIP. That was created as a public state-administered program for children in low-income families to fill a gap. People who earn too much to qualify for Medicaid but are unlikely to have the ability to buy insurance. So today the program covers 9.6 million children. And in some states it operates as an extension of Medicaid. In other states it's a separate program. And finally, the Affordable Care Act, established in 2010, otherwise colloquially known as Obamacare. And that was the most effective means to address the deficiencies and attempt to correct them as best could be done given the system. It includes requiring most Americans to obtain health insurance or pay a penalty, which was subsequently nullified. But it was a good idea. Extending coverage for young people by allowing them to remain in their parents' systems or coverage until age 26. Opening health insurance marketplaces with the concept that if the marketplace was there, they were more transparent, they were more competitive, and people could get a better deal for the insurance that they were shopping for. Expanding Medicaid eligibility in some states, but with help. Incentivizing cost controls for hospital services. That was a start the first time that was considered. And prohibiting denial of insurance due to pre-existing health condition. For those of you who know something about insurance, that was a big game changer for the industry. Employment-related programs could also be extended for 36 months after a person terminated their employment under what's characterized as the COBRA program. Many of you have probably seen that language in various form letters. Federal government kept its hand on the tiller to some extent with respect to administrative standards, but it's delegation, 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 delegation. One of the things that was important about that was that since insurance was an important alternative for people who didn't have it, they set up 4 categories of insurance, each of which had either higher premiums or higher coverage, down to the 5th category for catastrophic coverage, which was available only to people under 30 or who had a hardship exemption at any age. So the attempt was really to say, if whatever your pocketbook is and whatever your aspiration level is for risk, we have a plan for you. But it still didn't do the job. It just, again, put a few more Band-Aids and made the risks and the problems ameliorative. So now I'm going to talk about a criticism of that system that I've just kind of overviewed for you. As you see, it's a mixed system where publicly financed coverage coexists with privately financed market coverage. And out-of-pocket payments and market provision of coverage predominate as a means of financing and providing health care. As of 2019, about 50% of the citizens received benefits through private insurance coverage through their employer. 6% through marketplaces, insurance. 20% relied on Medicaid. 14% on Medicare, and 1% on other public forms. So a major flaw in the system is the way in which the services are classified and paid. Pay careful attention. This one really kind of will knock your socks off. Public and private hospitals receive payment from both public and private financing sources. Hospitals are paid typically through a diagnostic-related group, or DRG, which assigns a set payment amount for a particular condition or treatment sequence. Inpatient DRGs are widely used by centers for Medicare and Medicaid services as a standard, and also by many private payers as a payment scheme for hospitals. Rather than paying the hospital for a line item list of procedures, Medicare pays the hospital a fixed amount based on the DRG, regardless of the actual cost of the treatment. The DRG-based payments cover accommodation costs in a hospital, nurses, technicians, drugs. However, it does not include physician fees. In the outpatient setting, ambulatory payment classification codes, APC, are used by the hospital system for billing and reimbursement. These APC codes represent a fee-for-service style of billing rather than the capitated cost-based DRGs. Physician fees are not included with the DRG inpatient or the outpatient codes of the APC. When billing for physicians and other clinician fees, current procedural technology codes are used and are billed under the name of the provider rather than the hospital. CPT codes may be used in both inpatient and outpatient settings and are indicative of a fee-for-service healthcare reimbursement mechanism. If this sounds convoluted, I think you have an accurate description. Private insurers pay hospitals based on DRGs, case rates, per diems, fee-for-service, or discounted fee-for-service schemes, and the average of these payments exceed the hospital's costs of providing the underlying services. But, and conversely, hospitals are reimbursed less than their costs by Medicaid and Medicare and for uninsured patients. So this results in a lot of gaps between what people have gotten from various resources for the services that they get and what they are billed for. 4 in 10 people report that they or a family member has put off, postponed needed health care due to cost. 6 in 10 uninsured adults under the age of 65 say they have postponed getting health care that they needed. Similarly, uninsured adults are also more likely to report skipping recommended tests or treatment because they don't have the money. So health insurance does not offer, as you can see, ironclad protection, as more than a third of the people, even with insurance, still report not getting a recommended test or a treatment. And there's one surprise, one positive thing that I'll give you statistically, and that is that the cost of providing Medicare has flattened between 2010 and 2020, a $3.9 trillion reduction from the projections. Now, this is probably just going to be a temporary trend, but in fact, it was a surprise, and it is a positive development. Now, I'll just mention that the states have attempted, a few of them, to augment the deficiencies in the system by providing their own format to fill the gap. And the only one that I think is worthy of mentioning is Massachusetts. They established a healthcare system in 2006 that now covers, and then covered, 98% of the population. And residents whose income is less than 150% of the federal poverty level get primary care, doctor visits, emergency care, and core assistance. Health insurance acquisition or purchase by citizens is mandated, or a penalty is to be paid. But there's still a burden of uninsured, and that's picked up by emergency rooms, which are helped out by a state fund. So why is our system so costly? and I think you've already got some sense of it, and I'm going to elaborate on it now. Over 1/3 of all healthcare costs in the United States were due to insurance company overhead and provider time spent on billing, versus about 17% spent on administration in Canada. Cutting U.S. administrative costs to the $550 per capita, which is in the Canadian program, would have saved the United States more than $600 billion every year. The average American is paying more than $2,000 a year for useless bureaucracy. That's not my quote, that's Dr. David Himmelstein, a notable public health professor. And that, I think, is another bottom line to absorb. When researchers broke down the 2017 per capita health administration costs, comparing Canada and the United States, they compared them. And one of the most glaring one is that physician insurance-related costs in the United States were $465 versus $87 in Canada. Now, why is that? It's because insurance companies and healthcare providers are engaged in a tug of war, each trying in its own way to game the system. Professor Himmelstein said that, and so it's not from my opinion, but I do share it. How a patient's treatment is coded, this is another important point, can make a huge difference in the amount that the insurance company pays. For example, if a patient comes in because of heart failure, the visit is coded as acute exacerbation of the condition, the payment is significantly higher than if the visit is simply coded as a heart failure. Now, this upcoding of patient visits has led insurance companies to require more and more paperwork backing up each diagnosis, and the result is more hours that healthcare providers need to put the deal, close the deal with their billing. Now I'm going to compare a little bit what other healthcare systems are to ours. A number of the programs of developed countries, unlike ours, are single-payer systems, and they are mandatory in their participation. And the way in which the system derives payment varies from one to the other. So here are just a few that I'm going to touch on. And since I've been gave you negative information about California, we all think of the UK as having the poster child for Medicare and essentially free health care. Well, save your optimism, because a number of years of budgetary constraints imposed by the conservative government has really caused problems in terms of providers. The most glaring one is that new doctors in the UK are paid the equivalent of what a barista is paid in the UK. So they're definitely really strained, 12-hour shifts, pushed to the max, burnout is very heavy, and the lack of capacity results in unreasonable delays in treatment and increased mortality. The primary care deficit pushes much of the first response to illness to the emergency facilities, which also results in long delays. And other resources cause delays for months in any necessary surgery that is not an emergency. So you can have some consolation in the fact that even though ours is so flawed, others have similar or other flaws which are not necessarily attributable to the fact that they've got it right, we've got it wrong. Japan has an interesting program. It's different than the Brits. And there is funding for core services from taxes. The average person pays $5,700 per person in taxes attributable to Medicare medical services. There's also supplemental insurance to pick up the tab because a number of the services are not covered. The costs, the taxes, as well as the insurance modalities are calibrated to one's ability to pay. Now, this is not necessarily cause and effect, but coincidentally, as we know, the Japanese are pretty much the healthiest large group of people in the world. And I won't elaborate on the other factors, but it is important to keep in mind that there are intangible factors, and you can't just say, oh, well, it's all attributable to whether we provide good services, health services, or we don't provide good health services. That is not, whatever we do, a panacea, but the fact is that it's better if the services are good than if the services are bad, as I think I've already demonstrated. Canada is another illustration that I'll just briefly touch on, and its system is also universal health, and it's funded by taxes and by premiums. The government sets the standards, and then it delegates to the various federations, kind of like our states. And each one has to comply with, quote, 5 pillars of Canada Health Act, which stipulate that it be publicly administered, comprehensive in its coverage, universal, portable, and accessible without user fees. So then I think that pretty much gives you an overview of a few of the systems that are, unlike ours, universal. The fact is that we are really the only developed country that doesn't have a system that is universal. So that brings us to a question of, jurisprudentially, is healthcare a basic human right? The question has multiple facets: philosophical, ethical, theological, and political. Simplistically, rights are defined by the applicable laws adopted by a sovereign. Suffice it to say that while arguments can be made to support the premise, drawing from many sources, the only specific explication of this point is in the Declaration of the World Health Organization. Its constitution defines it as a state of physical, mental, and social well-being. That's an aspirational goal. And given that the United States never ratified the World Health Organization covenant, it's kind of academic. And we could say that in the United States, healthcare is no more universal than the right to affordable housing. But if not a right, it's certainly a priority because it's as basic and as necessary as the provision of electricity and water, and police and fire services. Certainly the need's universal. And that said, it's an imperative that the government not leave its provision to chance. If nothing else, the formulation of a policy and its implementation needs to be framed at least by cost benefit. So far, healthcare and how we go about obtaining it is a matter of choice. The approach is consistent with the basic societal values of individualism and personal freedom. Our system's detrimental to the society at multiple levels. The extra cost is a burden on the commerce that adversely impacts the competitiveness of business compared to other countries. And similarly, the financial burden of unaffordable medical costs impoverishes many families. The impact on mortality and marginally treated sickness has economic and social consequences. And a recent study published by the Journal of the American Medical Association punctuates the problem. The US has the highest maternal mortality rate of all the developed nations. It's disturbing that the study found that the mortality rates were actually increasing, and the disparity rates are high among minorities and the poor. And it's estimated that 45,000 deaths in the United States are attributable to a lack of health insurance. Similarly, the government's attempt to reduce the cost of drugs has met resistance from big pharma. Now, in exchange for supporting Medicare Part D, the government had to give up the option to negotiate drug prices. Current changes in the law, as you know, this past year, in the Inflation Reduction Act, give the government the right to negotiate on an initial 10 drugs, including blood thinners, cancer, and autoimmune disorder treatments. But drug makers have historically delayed the cost of patient protection by holding off innovations off the market for a matter of years, an approach driven exclusively by the maximization of profits. As seen, the American government's effort to improve healthcare delivery has been incremental and fragmentary at best. Efforts to make participation universal have been demonized with the label socialized medicine. The American Hospital Association and the American Medical Association have lobbied against universal health care consistently. A lack of social cohesion, dilution-related diffusion of responsibility between federal and state and local administrators, sclerotic bureaucracy are all impediments to meaningful change. The institutionalization of a significant for-profit component of the delivery system also impedes cost-saving initiatives. A lack of universal access amplifies the fact that the quality of care corresponds to the level of affluence. The affluent have access to the best procedures in the world. The poor are marginalized. Longevity disparities make the point. Poor American men have life expectancies comparable to those in Pakistan, while rich men lead the world in longevity. And U.S. mortality, maternal mortality rather, is 3 times the rate of other developed countries, and the maternal mortality in the African American community is double that. Now, would free health care lead to wasteful, unnecessary use? Economists have wrestled with this specific question, what they call the moral hazard. They recognize that reasonable and comprehensive insurance increases utilization. Is some of this hypochondriacal? A notable RAND study demonstrated that healthcare is not the same as Coca-Cola consumption. Regarding the latter, increase the price and the consumption reduces. In contrast, healthcare needs carry an imperative element. Imposing some reasonable, non-burdensome charge would not reduce the likelihood that a person would seek care for illness. It might mitigate overutilization. But if we're looking to reduce waste, the previously discussed expense burdens would be a better place to begin. So what can be done? Healthcare's current share of the GDP is in the long run unsustainable. The challenge is to reduce it while increasing the quality of care. What can be done to reduce the dysfunction? In the near term, the likelihood of adopting a program that covers everyone is virtually nil unless Democrats control both houses and the White House. Despite the mind-boggling intransigence of Republicans, it should be possible to elicit some support for cost-beneficial improvements that are not seen as giveaways. Here are 8 suggestions. Expanded federal negotiation of pharmaceutical costs. Expand the current list multiply. 2, aggressive administrative cost controls, meaningful ones, set benchmarks, and implement them with incentives, disincentives, a carrot and a stick approach. 3, set maximum charges for procedures with minor variations from region to region. 4, a federal fund to reduce or eliminate bankruptcy attributable to unaffordable health costs. 5, mandatory participation and a meaningful tax penalty for the failure to enroll in an acceptable program. Given the demographic time bomb of an aging population, the healthier young segment must all participate in pay for coverage, indirectly subsidizing the elderly. That's a principle of insurance when it works. Another improvement would stem from the reduction of for-profit insurer participation. And 7, the expansion of nonprofit delivery models like Kaiser Permanente would definitely result in cost savings and improved access to care. And 8, increased focus on wellness and prevention could reduce costs and generate broad improvements in health. Lee Hood, an advocate for early identification of genetic markers to prevent disease before it develops, points out that over 80% of our health expenditure is allocated to treating chronic disease. Making a dent in this problem would require the establishment of national metrics and a focus on wellness and early intervention as policy goals. Given the tension between federal and state governance, it's likely improvements in coverage or change enabling policy may trickle at random from state initiatives, but leaving it to these states will not result in a comprehensive solution. Over the horizon, we might yet adopt some version of universal coverage under the rubric of Medicare for all. Common sense dictates the need. It's not unreasonable to assume that savings could, as I said before, exceed $600 billion and result in a healthier society and a more competitive business sector. But let's not hold our breath. Now I'm going to conclude with the last words from Leonard Bernstein's adaptation of Voltaire's Candide. Any questions? And finally, thank you, I want to acknowledge my wife's participation. She's my editorial board, and she really is responsible for making this thing coherent. At least I hope you thought so. Okay.
So we have some time for questions from the audience. Andy?
You wait for just a moment for the microphone.
Thank you very much for a very good talk.
Thank you.
So who in the current state of affairs is doing well? Who is profiting? It's clearly not the patients. It sounds like it's not the hospitals. It could be the insurance companies.
Yeah, I think it's the insurance companies. That's correct. And I suppose you could say that this the modification in terms of the way in which the insurance companies have acquired practices extensely would indicate that at least while there's a burnout rate, while doctors are not particularly happy with becoming employees of large conglomerates, a lot of them are choosing that because it's preferable to the vagaries and uncertainties of private practice. So I suppose you could say that there's a certain cadre of practitioners who are benefiting, at least according to their standards. So, but other than that, it's mostly, as I gathered and pointed out to you, a losing situation.
So thank you, that was really excellent. I'm Sharona Hoffman. I teach the basic health law course here, and I think you gave the whole course in 1 hour. So I hope the students still keep coming to my class. I'll try to add more to it. So one problem that we and others are encountering is that it's actually not possible to get a medical appointment. They'll tell you have to wait 6 months, even if you have a serious problem. I have several friends who are encountering that. So I'm wondering if you have any comment on that phenomenon and any fix. That might be why Medicare costs are flattening, because nobody's getting medical appointments.
It could be an intangible. Yeah, I would say that the way in which that has to be addressed is kind of a question of supply and demand. As I pointed out with the UK model, not enough doctors being chased by too much demand. And it's real demand. As I said, it's not like Coca-Cola consumption. So the answer to that is that the government, to the extent that it can, should take the initiative and possibly subsidize a program to facilitate the entry of lots more people into medical practice. And of course, I'm kind of thinking about a historic model. In the early days of the Chinese, I'm not suggesting this is a proper model, but in the early days of the Chinese communist regime, they drafted all of these young people, gave them medical technical service, and sent them out into the countryside to address the fact that there wasn't any. So I think we could create a system in which we make it advantageous for young people to find this an attractive way to both to earn a living and also to do good. But I think what we're looking there at is another issue, which is we're seeing across the board in our economy, and that is that there just aren't enough people to fill any of the needs, whether we're dealing with truck drivers or in the industry that I'm in, the question of people functioning in wind energy. Everybody is desperate to find enough people. So The incentives certainly, from a pure economic standpoint, would probably help, but it won't cure the problem.
I have a question if no one else does. So, unless I missed it, Sheldon, one of the ideas that you did not suggest is a public option as to compete with private insurance in insurance exchanges and markets. Did I miss that, and if not, what do you think about that? So everybody know what a public option would look like. You know, there would be, you could buy Medicare even though you were under 65, something like Medicare, instead of buying something from Aetna or Cigna.
As I said, the Medicare for all would be a simple explanation for that, because it would be universal, and that is the equivalent of a public option. But the reason why my list was the way it was is that I just look at, Clarence Darrow said, government, like clothes, must fit the wearer. And the problem is, a broader initiative doesn't fit the American culture at this moment. And eventually it might, but not in the immediate future. And so my suggestion, pragmatically, was to look at things which the Republicans might say, yeah, that makes sense. I mean, I'm not demonizing all the Republicans. A lot of them are moderates. They don't like big government. They don't like taxes. But they do share a commonality with lots of other people in wanting a better life for themselves and for their families. So that's all. I just thought these things might work, and they would definitely make improvements, just as the Obamacare process did improve the flawed system.
Any other questions? We have time for two more.
Thank you for the talk. One of the things that I took away from your talk was that there's a problem. There are potential blueprints for solving the problem. But one of the biggest things that is creating an inertia for a solution to manifest is that there are vested interests, the healthcare insurance industry, which is significant. And practically it's not going away anytime soon. We live in a capital world. So how would you see potentially some steps that could be taken to ameliorate the impact that the healthcare industry has on policy making?
Well, that's, again, a kind of a macrocosmic question. What we've had now is increasingly kind of what could be characterized as a sort of a malignant capitalism. And I could talk about when it started and how it progressed. I mean, for capitalism right now is the, lots of people worship it, and they are not satisfied with a capitalism which is addressing profits with a common interest in improving society. So it's become rather one-sided and skewed. I think Peter Thiel is a very good example of that. Also, I won't even mention Mr. X. We all know who that is. So the only way that we can deal with that is by considering a long-term process in which we begin to temper our values and direct them toward the balance between making profit and innovation, and at the same time, not to the extent of depriving the society of its livelihood and well-being. It's not an easy solution, and obviously it pops up all the time. You see it through this, the healthcare system is full of instances, some of which I've anecdotally described. But we need to not only aspire to it and feel that, oh, well, we can't do anything, but recognize that we do have a kind of a dialectic that functions in history. And it can function as well here in the United States. We've reached perhaps a nadir, or at least we're pushing the bottom, but that means that there are opportunities for people to recognize the deficiencies and figure out how we can somehow or other as a society work our way through it. I hope that answers your question, but it's certainly mine. I don't feel that anything that we see is a cause for absolute despair other than in the near term.
Anybody else? You have
I might have missed this. You did say something about Big Pharma being a little contained by Medicare on 10 drugs, but why is Big Pharma allowed to make the outrageous profits that they do at the risk of being naive and have no, nothing holds them back pretty much?
Yeah, the answer to that question is that in our current state, the large economic institutions have an enormous impact and their capacity to mobilize support from the government. And you also have what I characterized before, and I think it's an accurate characterization, a sclerotic bureaucracy, which is, if not impotent, certainly ineffectual in doing its job. I mean, I could give you specific illustrations which are just outrageous, in which bureaucrats just kind of copped out, and we paid the price. So the answer to that is that they'll do what they can do if they can get away with it. And we, at this point, are, the way the government is functioning, we don't have as much leverage as we should have to curtail their activities, other than to identify them and then work on the, kind of in a log slog to curtail them. They make all kinds of arguments for, we're doing what we're supposed to be doing, and it's the best way, and we've got all of these great drugs, and we wouldn't have them if this, and they make a case, and a lot of people, legislators, buy that story. But it's as with anything, it's something that has to be addressed. And as Mao said, and I'm not a communist, but it was a good way to. He said, the long march has to start with the first step.
Thank you very much, Sheldon. Thank you all. For the reception, please join us. Is it upstairs or outside? I don't know. Upstairs. Okay, so if you climb the stairs that are right as you